Hello everyone, this presentation will be on neonatal jaundice. The slides are made by the Indian Academy of Pediatrics and are available online as a part of the IAP UG teaching module 2015-16. Now the presentation is mainly targeted at an MBBS student, and the purpose of an MBBS student knowing about neonatal jaundice should be to prevent bilirubin induced neurological deficit. Now in detail, an MBBS student should be able to recognize encephalopathy early and refer it early on, as well as to know about phototherapy, the basics of it, as well as the precautions to be taken, as well as the types available, as well as recognizing high risk groups, as well as use of the American Academy of Pediatrics charts. Apart from this, an MBBS student is expected to be able to clinically assess a neonate in addition to having basic knowledge on feeding, prematurity, the importance of prematurity, the importance of blood group incompatibility, as well as about cephalematomas. By definition, jaundice is a visible manifestation of the skin and sclera of elevated serum bilirubin, and in adults we know that it occurs when there is an elevation more than 2 mg per deciliter, but in neonates it is visible only where more than 5 mg per deciliter. Now almost all neonates have chemical hyperbilirubinemia, that is bilirubin levels of more than 2 mg per deciliter, and 60 to 70% of all term newborns as well as 80% of preterm newborns have physiological jaundice. Now if we understand the metabolism of hemoglobin, we know that in red cells hemolysis occurs, which results in hemoglobin, and hemoproteins also undergo turnover, which results in the separation of hemoglobin into heme and globin. Now globin will get recycled and heme further will undergo oxygenation based on the enzyme heme oxygenase, and in addition to that the action of NADPH and oxygen in the presence of cytochrome C that is present on P450. NADPH gets oxidized to NADP, oxygen gets oxidized to water, and iron is also formed in the ion form, that is Fe2+. Now what we started out with as heme becomes biliverdin and carbon monoxide. So we have biliverdin and carbon monoxide. We'll first focus on this carbon monoxide part. Carbon monoxide, one component of it will go on to form cyclic GMP, and oxyhemoglobin will get converted to oxygen, resulting in the formation of carboxyhemoglobin, and this carboxyhemoglobin gets exhaled in the form of carbon monoxide in trace quantities. Coming back to biliverdin, biliverdin gets reduced to bilirubin in the presence of biliverdin reductase, and simultaneously there is an oxygenation of NADPH to NADP. Now bilirubin further gets converted to bilirubin diglucuronide, bilirubin monoglucuronide, which gets excreted into the intestines and to the gallbladder, and some amount of enterohepatic circulation does occur and results in the reformation of some amount of bilirubin, which undergoes the same conjugation once more. Now the same bilirubin physiology, if we understand, we'll start here with bilirubin. Bilirubin in the presence of ligandin Y acceptor will result in the formation of bilirubin monoglucuronide and bilirubin diglucuronide in the presence of glucuronyl transferase. This is nothing but conjugation. So we know that this conjugation reactions do occur in the liver, and it results in the formation of bile, which gets excreted into the small bowel. Now in the small bowel it further undergoes change into stercobilin as well as beta glucuronidase. Stercobilin gets excreted directly, and beta glucuronidase undergoes deconjugation, which goes back to enterohepatic circulation. When I say enterohepatic recirculation, I mean that it comes back to the mainstream and results in conjugation once more de novo to where bilirubin monoglucuronide and bilirubin diglucuronide are present. This is a simple overview of the bilirubin physiology. Now, when we say physiological mechanism of neonatal jaundice, we should understand a few key concepts. Firstly, there is an increased bilirubin synthesis in the initial days after birth, because there is a lot of conversions from fetal hemoglobin to adult hemoglobin, as well as other changes such as some amount of minimal hemolysis as well as transitional changes which do occur at birth. Secondly, there is less efficient binding and transport of bilirubin due to enzyme deficiencies, and less efficient hepatic conjugation and excretion due to deficiency of glucuronyl transferase and the conjugation enzymes. Apart from this, there is also enhanced absorption of bilirubin via the enterohepatic circulation. This enterohepatic circulation is more active in neonates comparatively, as a result of which there is physiological jaundice. Now, generally, physiological jaundice appears between 24 hours and 72 hours of life, but by definition, it must be after 24 hours of life to call it as physiological jaundice. The peak serum bilirubin levels are seen between the third and the fifth day of life in term neonates. I am repeating this, between day 3 and day 5 in term neonates and day 3 and day 7 in preterm neonates, and generally does not exceed 15 mg per deciliter. Apart from this, it does not persist for more than 2 weeks in a full-term infant, and generally treatment is not required. It spontaneously settles on its own. So, to clinically assess about neonatal jaundice, we have what is called Kramer's rule. Now, we know that, assuming this is the baby which we are considering, if the level of jaundice is present merely at the head and neck, it is between 4 to 8 mg per deciliter. Present up to the upper trunk, I'll change the color in this to make it better understood. So up to the head and neck, it is 4 to 8 mg per deciliter. Up to the upper trunk, it is 5 to 12. If it involves the lower trunk and the thighs, it is 8 to 16. If it involves the arms as well as the lower leg, it is 11 to 18 mg per deciliter. And if palms and soles are completely involved, then it is more than 15 mg per deciliter. One general observation, if you noticed here, based on Kramer's rule, the progression of neonatal jaundice varies, and the progression generally goes cephalocaudally. It starts from the head and neck, goes to the upper trunk, lower trunk, subsequently goes on to the limbs. Now, if we have what is called as a physiological jaundice, we should also have what is called as a pathological jaundice. If there is clinical jaundice in the first 24 hours of life with total serum, it is pathological jaundice without a second thought. The other criteria to label it as pathological jaundice include serum bilirubin more than 17 mg per deciliter, the rate of increase being more than 0.2 mg per deciliter per hour or 5 mg per deciliter per day. If the direct serum bilirubin is more than 2, or if the clinical jaundice is persisting for more than 2 weeks in a full-term infant. All of these are criteria to label this as pathological jaundice. Now, if we come to the causes of pathological jaundice, I am re-emphasizing on this point once more that it appears within the first 24 hours of birth. The causes as such are Rh incompatibility as well as ABO incompatibility. Blood group incompatibility is a cause of pathological jaundice. Apart from this, it can be because of G6PD enzyme deficiency, pyruvate kinase enzyme deficiency, or because of infections, that is sepsis. Could be a torch infection, it could be bacterial, or it could be malaria also. Now, if we consider the causes of jaundice age-wise, what we saw initially was pathological jaundice up to 24 hours of life. Now, if we consider 24 to 72 hours of life, physiological jaundice is the most common. Apart from that, it can be because of polycythemia, it can be because of extravascular blood collection, which could be because of a cephalhematoma, it could be because of a subgaleal hematoma, it could be because of an intraventricular bleed, it could be because of a subarachnoid hemorrhage. Increased intrahepatic circulation is also seen in intestinal obstruction, and these are the common causes up to 72 hours of life. Now, post 72 hours of life, it still can be a physiological jaundice, but other causes do need to be ruled out, such as neonatal sepsis, cephalhematoma again, neonatal hepatitis, extrahepatic biliary atresia, and breast milk jaundice. Apart from this, by day 3 of life, we do need to rule out other metabolic causes like hypothyroidism, hypopituitarism, Crigler-Najjar syndrome, and Gilbert disease. What I listed out here were the causes of neonatal jaundice beyond 72 hours of life. Now, coming to breast milk jaundice, it may persist as a prolonged physiological jaundice, or it may even appear de novo after the first week. It is commonly seen in exclusively breastfed infants, and the maximum intensity is noted between 10 to 14 days. If the serum bilirubin level is more than 15 mg per deciliter, I repeat myself, more than 15 mg per deciliter, then a temporary cessation of breastfeeding for 48 hours is recommended, and this results in a dramatic fall, and subsequently it does not rise again. But this is a bad practice because it disrupts the feeding pattern, and therefore it must be avoided. The best thing to do for breast milk jaundice is nothing but phototherapy, but the exact pathophysiology of this is still not understood. Now, if we do approach a jaundiced baby, then there are a certain set of protocols which we must follow. First thing what we should do is record the birth weight. From the records available, know the gestational age of the baby at birth. Note the postnatal age in hours also, up to day 3, followed by number of days. By assessing the child, we should know whether the baby is well or ill, mainly based upon a few criteria, namely the activity of the child, whether the child is active between feeds, the cry of the child to ensure there is no irritability. Color, of course, will be jaundice if there is neonatal jaundice present. Apart from that, clinical assessment of capillary refill time and peripheral pulses is a must to know whether the child is well or not, and whether the child is passing urine and stools adequately. These are all indirect indicators of health of the baby. If it is a physiological jaundice and the baby appears well, merely observation itself is sufficient. But if deeply jaundiced, to look for signs of kernicterus, that is, deposition of bilirubin within the basal ganglia known as kernicterus. It is a sequel of neonatal jaundice. The signs of kernicterus include lethargy, poor feeding, poor or absent morose reflex, hypertonia, opisthotonus, and convulsions. Any of these warning signs present, immediately must go for an intervention. Now, if we classify kernicterus into acute and chronic, we'll consider acute kernicterus first. Stage 1 will be merely lasting for a few days, and in a few days we will have lethargy, poor sucking, and hypotonia. By the mid of the first week, it will go into stage 2, where there will be a rigid extension of the extremities. It can go in for seizures, high-pitched cry, opisthotonus, as well as retrocolis as well. And stage 3 after the first week, where the presence of stupor, coma, or marked opisthotonus will occur. In chronic kernicterus, it can go in for movement disorders, gaze abnormalities, as well as auditory abnormalities, and can even lead on to mental retardation. To work up a jaundice newborn, we need to take a detailed maternal and perinatal history also. This includes the blood groups of both the mother and the father, to know the details of the delivery, where it was conducted, who conducted it, any difficulties, any instrumentation which was used, and a full physical examination from head to toe. Lab investigations wise, a total and direct bilirubin is must to be done, and blood grouping and RH typing are additional investigations to be done on day 3. Severe jaundice requires the workup of hematocrit. A complete blood count is ideal, and in low resource setting, at least a hematocrit and a reticulocyte count is sufficient, along with a direct Coombs test of the baby. If prolonged and a sick child, better to go in for a sepsis screen and a liver function test as well. Now, thyroid test has a significance because hypothyroidism can result in prolonged neonatal jaundice, but in common practice, a detailed thyroid workup is generally done on day 3 of life as a screening test for congenital hypothyroidism, because congenital hypothyroidism is the most common cause of preventable mental retardation. So therefore, it is commonly done in most settings on day 3 of life itself. Now, the aim of managing a neonatal jaundice case is 3. Firstly, we want to arrest the rise of serum bilirubin total levels. So after preventing the rise, we want to reduce it and thereby prevent neurotoxicity also. To prevent jaundice in a neonate, a few key points to keep in mind. Firstly, there must be early and frequent breastfeeding to the child from the mother. Adequate hydration of the mother is to be maintained, and thereby ensuring by frequent feeds adequate hydration to the baby also. And administration of anti-D to RH negative mothers when the baby is proven to be RH positive immediately after birth. Now, to prevent neurotoxicity, there are 2 interventions what we commonly go in for. One is phototherapy and one is exchange transfusion. Now, phototherapy is basically because of the reduction of bilirubin levels by photooxidation of the bilirubin. This photooxidation results in excretion of the bilirubin into the bile, and subsequently it is removed through the stool. The babies are generally kept in blue light in the spectrum of 450 to 460 nanometer wavelength with a irradiance of 6 to 15 microwatt per centimeter square per nanometer. Now, generally the baby is exposed at a distance of 30 to 45 centimeter, and the eyes and genitalia of the baby should be covered during phototherapy. Frequent feeds are to be given every 2 hours, and frequent change of posture is recommended. The first change which occurs is the configural isomerization of bilirubin to 4Z15E form, and we know that there are E and Z isomers. The native form is Z, but it gets converted to E. The E form is more polar and therefore more water soluble, and thus gets excreted out easily. But it's important to note that this reaction is reversible, so there can be a risk of reabsorption through intrahepatic circulation, so it's important to continue phototherapy as long as needed. The second reaction which occurs is because of the structural isomer known as lumirubin. This is an irreversible reaction. The first one between E and Z form was reversible, and lumirubin is irreversible step, and as a result of which there is no reconversion, and hence it cannot be reabsorbed. So as more and more of this lumirubin is formed, the more and more it gets excreted, and this is generally done with high intensity phototherapy and a higher irradiance at a shorter distance. Now when I say the concept of irradiance, if this is the bed and this is the light source of phototherapy and this is the baby, so if that is a baby, I'll just use blue to depict the phototherapy wavelength. The closer the baby is, the more the irradiance is. The farther it is, the more the same amount of light gets scattered. So the closer it is, higher the intensity. And that's why if you notice here, there is a shorter distance mentioned of 15 to 20 as opposed to 30 to 40 mentioned earlier. The temperature of the baby is monitored every second to fourth hourly, and weight is checked every day. More frequent breastfeeds are given, and IV fluids are given if the signs of dehydration are present in the baby. And by protocol, it is recommended to measure the serum bilirubin every 12 hours initially, but new guidelines do recommend that measurement every 6 hourly is better. And phototherapy is generally discontinued if two values are less than 10 mg per deciliter. The reason for two values is to ensure that it is not because of the reversible form and the irreversible oxidation reactions have occurred. Now, as with any intervention, phototherapy has its disadvantages. The disadvantages of phototherapy are increased insensible water loss, passage of loose stools, that is diarrhea. It can go in for either hyper or hypothermia. It can even result in UV light irradiation or bronze baby syndrome. Now, bronze baby syndrome occurs where phototherapy is given for conjugated hyperbilirubinemia as opposed to unconjugated. Before going in for exchange transfusion, I will mention about conjugated and unconjugated form. We do have a total bilirubin in the report, and we have a direct bilirubin. Total minus direct gives you the indirect. This indirect bilirubin represents the conjugated form, direct bilirubin represents the unconjugated form, and total is of course the total. So I just wanted to brush up on that fact, which I should have done initially. But bronze baby syndrome, if there is a direct bilirubinemia and you give phototherapy, that is what happens. The intervention for direct bilirubinemia is entirely different and is generally a surgical approach. Now, exchange transfusion is a more effective and reliable method, and it decreases the risk of bilirubin encephalopathy by reducing the total bilirubin load, increasing the binding sites of plasma albumin, shift of bilirubin out of plasma, and it removes the sensitized RBCs also. To go about an exchange transfusion, first the umbilical venous catheterization is done, and 5 to 10 ml are removed and replaced sequentially until double volume is replaced. Now, we know that a neonate contains 80 ml of blood per kg. So when I say double replacement, 160 ml per kg has to be replaced. So this is known as DVET, that is double volume exchange transfusion. When we come to the choice of blood, if there is an ABO incompatibility, it is ideal to use O positive blood because O positive cells will still get suspended in AB plasma also. And in case of RH isoimmunization, then better to go for O negative blood because even O negative blood will be suspended in AB plasma. So based upon the choice of blood depends mainly upon the blood group of both the baby and the mother. Now what we are seeing here is what we call as a Mischel chart. The Mischel chart helps in determining our intervention. So based on this, if we go, if the bilirubin level is less than 5 irrespective of birth weight, no need of any intervention. Between 5 to 9 mg per deciliter irrespective of birth weight, phototherapy is given for less than 24 hours if there is evidence of hemolysis. Now between 10 to 14 mg per deciliter depending upon the birth weight, if presence of hemolysis is there, go for exchange transfusion, and phototherapy for duration as long as needed if the birth weight is less than 2.5 kg. More than 2.5 kg, go for further investigation. 15 to 19 mg exchange transfusion to be considered initially, and later on consider exchange or phototherapy if the need be for low birth weight. This 24 depends on the number of hours of life, and this is the further hours of life here. Subsequently, if levels are more than 20, irrespective of birth weight, go for exchange transfusion. So I'll repeat it. In the first 24 hours of life, depending on the values, less than 5 don't need to do anything. 5 to 9 go for phototherapy if there is hemolysis, and beyond that, irrespective of birth weight, go for exchange transfusion on day 1 of life. On day 2 of life onwards, up to 10 milligram per deciliter, no need to do anything, and consider phototherapy from day 2 onwards if the birth weight is less than 2.5 kgs. More than 2.5 kgs, go for further investigations, and if levels more than 15, consider exchange transfusion. That is in a nutshell about Mischel's chart. Now, Mischel's chart is used for making decisions in the presence of the following. We must treat in the next higher level. If the baby has perinatal asphyxia or respiratory distress or metabolic acidosis, or is an extreme low birth weight of less than 1.5 kg or signs of CNS involvement, then you must treat differently and go for a step-up approach. Now, I will highlight what we call as the AAP normogram. This is the AAP normogram. So, if we consider a baby in this graphically, so we will assume for a case now. If we assume a case of a 38-weeker born and presenting with a total bilirubin level of 10 at 24 hours of life. So, on 24 hours of life, now before that we'll understand what this graph represents. This dotted line, what you see here, is medium risk here, the middle one, that is medium risk. Then we have a high risk line, which is here, which is the presence of risk factors, as you can see here, and we also have a low risk line. The low risk line is seen in the small dots, what I've traced. Now we'll come to the same case what I mentioned, a 38-week gestation baby on day 3 of life, weighing 2.5 kgs. Okay, I'll make it 2.6 kgs for easy understanding, and no additional risk factors, and we have taken this at 24 hours of life. So on 24 hours of life, I will plot the first line, and I said the total bilirubin was 10, so I will plot 10 along here. Okay, so this is the point of intersection. So that point of intersection falls on the middle line. The middle line is to show anything above the middle line requires intervention if it is a medium risk. It is below the line for low risk and above the line for high risk. Because this was a low risk baby, there is no need to do anything on 24 hours of life. Now, the same baby we will consider on day 3. So the same baby did not require any intervention on day 3. On day 2. So on day 3, we will consider the same baby of 38-week gestation. Today, on day 3, baby weighing 2.8 kgs. At birth, it was 2.5, gaining weight well. And because it is day 3, we have repeated the bilirubin level because baby is still ecteric and is appearing to be 15 on day 3. So on day 3, level of 15. So I will draw the same line here, that is for day 3, and 15 will come here. So it is here. It falls under medium risk again because the line comes along the plateau for medium risk, but the baby is still a low risk baby. So as a low risk baby, there is still no need to do anything. You can wait and watch. We'll consider the same baby after another 24 hours. The bilirubin levels have now become 21. Same 2.8 kg baby on day 4. If you notice, the same child has consistently been having an increase in the bilirubin, but we'll plot it for day 4 on 96 hours of life and 21. Now here it is coming above the line for low risk also, so phototherapy is indicated. So based on this case, what you understood is how to plot a serial charting of bilirubin. Now we'll consider the same case here. On day 1 it was 10, we repeated it on day 3, it was 15. Baby was still ectric, on day 4 it became 21. So if you do consider the plot, there has been a gradual rise, it never decreased. So if we ask ourselves what better clinical intervention could have been done, prophylactic phototherapy, definitely on day 1 we could have waited, but on day 1 itself when ectric, this scenario could have been better handled by giving phototherapy initially on day 1 itself, because we know that within 24 hours of life, presence of any amount of neonatal jaundice is significant and requires intervention. But still we chose to take a wait and watch approach. On day 3 when it was borderline and still ectric, at least here we could have started, but we waited until day 4 where it gradually increased. So based on this case, what we understood is it is better to go for an early intervention if identified early, and our ultimate aim is to go for early identification, so the baby ultimately will get better soon as well. Like I was mentioning about conjugated bilirubin, we define it as direct serum bilirubin more than 2 milligram per deciliter. That is the definition for conjugated. And if conjugated bilirubin is present, we also should look for other factors such as high colored urine, white or clay color stool, presence of jaundice beyond 2 weeks, as well as hepatosplenomegaly also. Generally what we come across is unconjugated jaundice. This can be because of idiopathic hepatitis, bile syndrome, infections such as hepatitis B, torch infections or sepsis, metabolic conditions like galactosemia, fructose intolerance, alpha-1 antitrypsin deficiency, glycogen storage diseases, hypothyroidism, or even a baby which is on total parental nutrition. Before concluding the presentation, I'll just show an image of a baby in phototherapy, so we'll have a better understanding with that. Now what you see here is a phototherapy unit. Now we have the overhead phototherapy device. The reason I put this image is you can see both double surface as well as single surface phototherapy units simultaneously. Now this is the overhead phototherapy device, what I am highlighting here. I'll use a different color to make it stand out. I'll use red. So what I am highlighting in red is the overhead phototherapy device unit. This is maintaining the distance of 30 to 40 centimeters from the baby. The eyes and genitals of the baby are covered and phototherapy is being administered. Now what you are seeing here is a single surface phototherapy, because this is where the radiations are coming from. So this is a single surface phototherapy, SSPT. So the light source is coming from one side. Now if you see over here on this side what these babies are getting, this is the overhead phototherapy unit and this is the undersurface phototherapy unit. So there is source of radiation coming from below as well as from above both. Because it is coming from both 1 and 2, this is a double surface phototherapy unit. Now apart from this, you also have triple surface. Now because triple surface is not shown in the image, I will just diagrammatically show it such that it will be understood better. For a triple surface unit, there will be one from below, one from each side also, and triple surface is also known as high intensity phototherapy. So this is just to make the concept a little bit more clear rather than just merely talking a bit of theory, an image also to depict how phototherapy is given. On that note, I thank you all for listening to the presentation and hope it was informative and that the concepts were clear. I hope you also tune in to the subsequent presentations, and I thank IAP for ensuring that these slides are available for the educational purpose. Thank you.